So the story goes, I see patients at Children's Hospital Los Angeles. We started a program around autism evaluation there and had an opportunity to meet a couple of patients from Guam and heard the story, heard about challenges. Not that dissimilar to what we see in LA, actually, believe it or not. So I had a chance to meet with the folks from Guam and started talking about how do we start to address some of the disparities, because it's very similar work to what we do in LA, is addressing disparities in service. And so that started this whole relationship around building capacity around autism spectrum disorder in terms of evaluation. And obviously that has evolved into intervention in the early childhood years. And then where we ultimately want to go together is to think about now next steps around older kids, right? And our USAID in LA has been doing some work around social skills for adolescents, especially during the pubertal years, right, when kids are maturing. And we're also working on programs and internships around employment. And so we have a few programs like that. And so, that was part of why I wanted to come out, and this was kind of the natural next steps into what can we be developing together and how do we support folks on Guam, as well as build up our own capacity within LA. And so that's kind of the backstory of all of this. And so tonight's talk is really about co-occurring conditions in children with autism spectrum disorder. For those of you who don't know, my research interests are in health disparities and population health approaches to address disparities. Much of my work has been in autism spectrum disorder, but we also do some other work around physical health conditions and folks with developmental disabilities as well. So we'll get started, and hopefully we'll have, I'm sure we'll have time for questions. And if you have questions, just stop me, and feel free, and we can try to address those. And then we'll also have time at the end for questions, and hopefully I'll have some answers for you too. So these are my disclosures. And so just a brief note on terms. Nowadays, we talk about person first versus identity first. So person first, a child with autism, versus identity first, the autistic child. And it's interchangeable now, right? So adults who are on the spectrum some adults prefer identity first, right? Some adults prefer person first. So it's all, it's up in the air that way. And so if you hear me talking about both interchangeably, that's why. We're moving away from this idea of a disorder. Autism isn't a disorder, okay? It's really a child with ASD or a child on the spectrum. It's not a disorder. We're trying to get away from the use of the term normal. So we want to use typically developing, neurotypical, or child with typical development, okay, instead of using the term normal. And we're also trying to get away from high functioning as a descriptor of somebody who has autism spectrum or low functioning, right? We want to change that into more high or low support. And so when we're talking about kids who are on the spectrum, it's that as a way to kind of to share with others kind of what are those needs and what are the level of needs, rather than saying high or low functioning. Okay. So why is recognizing co-occurring conditions important? We know that children with ASD have many of the same physical and mental health conditions as children without ASD. And that some of these conditions happen actually more often in kids with ASD. And conditions often start in childhood and they continue on into adulthood as well. The other reason why this is important is that underdiagnosis, so not recognizing these conditions, really can impact quality of life. It can lead to earlier mortality, so earlier death. Lower adaptive skills, which means higher support needs, right? Poor long-term health outcomes, and then lower executive functioning, cognitive ability, decision-making, information processing as well. And so, why is it challenging to diagnose these co-occurring conditions? Well, there's multiple factors. There's challenges with communication, right? So often, folks who are on the spectrum have difficulty expressing themselves. they'll have difficulty sharing what the symptoms are, right? And they actually might resort to new behaviors that really reflect pain and discomfort rather than aggression, right? Or rather than vocalizations, things like that. Kind of like as last night, it's that interpretation of behavior and what is part of the individual's kind of daily routine in terms of behavior, and actually what might also reflect or variably affect an underlying condition. We know that medication-related side effects also cause other challenges. So patients who are on what we call serotonin reuptake inhibitors, so probably you all know Prozac, right, or Zoloft. Those kinds of medications, you can develop dry mouth. And then when a child who's nonverbal starts to develop dry mouth, what they're going to try to do is create some saliva and spit to wet the mouth, right? And then you can develop a whole new behavior now. So what parents are seeing is, why is my child spitting more? And so it goes back to kind of like, well, what are the medications? What are the side effects? And what's the adaptive response that that child is now exhibiting to counteract those side effects? And so it's not necessarily a new behavior related to autism. It's a behavior related to a side effect of a medication. And so it's trying to think about things in that kind of light, in that kind of setting, to give you more information about what could really be going on. And that's a true story, by the way, of a patient that we saw. And then nutrition and nutrition-related diets, right? Nutrition-restrictive diets that lead to mineral or other nutrient deficiencies are also a challenge, and it's very common in this population, especially when you think about the restrictive diets and how that impacts micronutrients and minerals, right? And so we'll be talking about physical health and the impacts in GI, neurologic concerns, as well as sleep tonight. And then we'll also be talking about mental and behavioral health challenges that are also associated. Oh, you're just getting your glasses. Okay, I thought you were going to raise your hand. You're okay. You're okay. We're all amongst friends, right? Okay. So, on the GI side, the prevalence of GI disorders, meaning how often this occurs, it's a wide range. It's 9 to 70%. And so what we often see is things like constipation, GERD, which is gastroesophageal reflux disease, and that's like when the stomach contents come back up, causes heartburn. Esophagitis, burning of the throat that happens with GERD too. We talked about food selectivity, intolerance, irritable bowel syndrome, inflammatory bowel disease, celiac disease, and pica. And pica is a condition where you're mouthing objects that are non-nutritive, okay? So putting non-edible objects in your mouth. And so, the things that can present with GI disturbance or GI challenges are poor weight gain and growth, and that you'll see that in conditions like inflammatory bowel disease, or in macro as well as micronutrient deficits from the selective diets. And then in celiac disease, you typically will see this. And usually with celiac disease, what you see in kids who have more severe celiac disease is in that first year of life when you introduce solid foods and you start to introduce gluten, they start to fall off the growth curve because they're having diarrhea. In those kids who have partial challenges with celiac, what you'll see or what you'll hear about is stomach pain, diarrhea, and then ultimately, eventually some slow growth, okay? When we hear about like tapping on the chest for no apparent reason that all of a sudden emerges, we start to think about things like gastroesophageal reflux disease, because it's that feeling of pressure coming back up, or esophagitis. When we hear about abdominal pain or irritability that comes and goes, we think more about things like constipation or irritable bowel syndrome. And then in families who have inflammatory bowel disease, you have to also think about Crohn's disease, and you'll think you'll hear more about diarrhea that's actually bloody, okay? As well as then ultimately decreasing height velocity in their growth. When we hear about chronic diarrhea, abdominal pain, we think about inflammatory bowel disease as well. And then when we hear about something called restless leg syndrome, so literally the leg is just going up and down, up and down, up and down, or when they're sleeping, the legs are moving, things like that, we start to think about iron deficiency from food selectivity, or from pica. And so when you put things in the mouth that are non-nutritive, you're going to be more at risk for things like lead poisoning, right? Lead toxicity. And then when you have higher lead levels than you should, that competes with iron, and that's why you become iron deficient. And that's why you need extra iron, in fact. And then the things that warrant consideration for further testing to think about is if you're running into a situation where your child's losing weight and you have no idea why, and they're eating the same amount. That should spur you to think, you gotta look further. The growth curve, the height curve, every time you go to the doctor's office, they measure, see how tall you are. If that's starting to fall off, that should kind of trigger your thought into, we need to look into this further. Significant vomiting, so cyclical vomiting, vomiting that occurs once a month, and it lasts 3 days, and then it goes away. But then the next month it comes again. Well, that's a pattern now that you don't typically see, and that's not necessarily autism related. And that should be evaluated as well. Protracted vomiting, so vomiting that just lasts forever, meaning gets to the point where it's like 2 weeks vomiting. And then if vomiting ever looks green, like bile, that's something that needs to be addressed right away, like probably that night in the emergency room, okay? So blood and bile in the vomit, never okay, and that should always be evaluated. Chronic diarrhea obviously should always be evaluated too, so diarrhea that's lasting more than a couple of weeks, right? So we know from just regular infections that kids get, usually lasts for up to a week and then it gets better. If diarrhea is happening for more than 2 weeks, start looking into what's going on there. Anything in the right upper or lower quadrant and pain, you want to think about, right? So right in the right upper quadrant, you're thinking about liver, and anything that could be causing inflammation of the liver that's causing pain. Right lower quadrant, you have to think about the appendix and thinking about could they have appendicitis, and especially in kids who are nonverbal because they can't tell you, right? But if you push on their belly, push in the right spot, they will wince and they will have pain, some of them. But the other problem is a lot of these kids have high pain tolerance, so they won't tell you. And all you're going to know is their behavior is changing, right? And so that's why you got to start thinking and thinking more deeply about what also could be going on. Talked a little bit about family history of inflammatory bowel disease. So if that is in your family, Crohn's disease, ulcerative colitis is in your family, and now a child is developing, slowed growth, chronic diarrhea, bloody diarrhea, that's something that needs to be evaluated by the GI specialist. And then any kind of atypical and or unexplained physical findings as well needs to be kind of looked at further from a GI perspective. Typical evaluations in the studies, you typically will look at stool, look for bacteria, blood. You look at enzymes to really look for malabsorption kind of processes that could be occurring. Blood tests to look at electrolytes, look at the liver. X-rays to look for constipation, to look for obstruction of the GI tract, meaning the flow is blocked and so the bowel is inflamed. Endoscopy by the GI specialist to look actually at the bowel through, with a camera to see what's going on, and then colonoscopy on the other end to see what's going on. And then really assessing nutrient status. Some of the empiric treatments, meaning, something that you can do right away in the office, right? And so if there's issues around kind of diarrhea, gas, and you get this history that it really happens more with dairy products, right? Ice cream, cheese, milk, you can try a lactose-free diet and for a few days and see if it gets better. And just go switch over to a lactose-free milk and see if that gets better. And that will help you. For GERD or gastritis, what we'll typically try, if we're really feeling like the symptoms are consistent with reflux, we'll try what's called a proton pump inhibitor. And that's basically a medication that decreases the amount of acidity in the gut. So it blocks the gut's ability to create acid in the stomach. And then you see if the symptoms of the chest tapping or the waking up in the middle of the night trying to gasp for breath gets better. For constipation, it's the miracle of Miralax. I think one of the things about polyethylene glycol, and there's many different brands, is that it works by drawing water into the bowel, right? So you have to drink a lot of water. And so if your child's not drinking enough water, the medication's not gonna work, because essentially you're not getting enough water into the bowel to help the bowel move all of that stool out, okay? And so that's what we say when we're saying, we can try the Miralax, but you're gonna have to drink 8, 10, 12 bottles of water a day, okay? And to try to force that amount of water in is sometimes difficult, right? Sometimes we'll try to go the other side and do enemas to try to clean out the bottom and try to get things moving that way too. So constipation is usually defined as from 2 weeks or more of a delay or difficulty in passing stool. There's so many causes to constipation that we don't have the time to get into, but it really just starts with thorough kind of medical history, diet history, and the more information you can give to the physicians about that, the better it can help them think about this. Thorough physical exam, so hopefully somebody's doing a physical exam they're looking at the bottom. Sometimes they'll do a rectal exam to make sure to see if there's stool actually in the rectum that's consistent, that's hard, and for constipation. For younger kids in the first year of life, second year of life, they'll look at the back and the spine to make sure there's no kind of spina bifida, occult spina bifida, or something called neurotube defect that affects the neurologic system in the lower extremities, and then obviously a neurologic exam. And so when you think about the causes, the most common reasons why kids who are on the spectrum have constipation is really diet related. It's a diet that's typically low in fiber, high in carbohydrate, very low water intake, and lack of exercise. So you can treat with Miralax and add water, but to get the bowel moving, the child has to move too. And so if you can get the kids walking more, exercising more, that will actually help the bowel move too. And that will help you get rid of the constipation. And usually what happens is parents often will stop the Miralax after like a day or two, right? And then because, they pooped a lot. It seemed like a ton in the bowl. And you're like, they're not done. You want to keep giving this until the stool is loose and almost clear. Then you know the bowel is actually clear. And then you can go back and then you can kind of wean off the Miralax, okay? And so it's really kind of giving it enough time to really make sure it's soft and, be ready, right? It's not a fun task, but once they're cleared out, they're gonna feel a lot better. And their behaviors actually might then get better too. And so if you've ever, had to deal with the constipation, you'll know the gas pain is severe and it's intense. And they will be screaming in pain and you'll think like, what the heck is going on? And so you rush to the hospital, they do an x-ray and the x-ray will say, it'll look like they have so much stool. And then once you get them cleared out, life is good again. And then it's back to that daily regimen of, of enough fluid, exercise, and trying to improve the amount of fiber in the diet. For chronic diarrhea that's loose stool for more than 2 weeks, the evaluation again, history, thinking about when it started. The information that folks want to hear on the medical side is, when did this start? Did it happen a week ago, 2 weeks ago? Did it start with a fever? Did it start with, after coming home from a field trip? Things like that, okay? And if the more information you can give around that, that gives the providers more and more clues as to what it could be. And for the other things around evaluation is really assessing growth, nutrition, and some stool studies. One of the more common reasons why kids with autism spectrum disorder have loose stool is because they actually have chronic constipation. So it doesn't really make sense, right? Constipation, delayed stool. But if you get so backed up from constipation, you actually get leakage around the block, and that comes out as loose stool. And so until you get rid of that block, you're still going to continue to have loose stool. Lactose intolerance is another thing that can cause chronic diarrhea. Food allergies, so are less frequent, but thinking about that, certain foods are causing this, then definitely go in that route. Celiac disease we talked about, infection. And so in kids who have pica, they might be actually more at risk for infectious disease. And so things like Giardia, it's a common parasite that kids can get, and it leads to chronic diarrhea. Giardia is very common in preschools. So if you have a preschooler who's having diarrhea for more than 2 weeks, they have to think about Giardia, right? The doc needs to think about Giardia. You're going to hear is watery stool for 2 weeks. And that's a simple stool culture. And then there's other kinds of bacteria to think about as well. Again, more for the doc to think about, and will come out of culture when you actually culture the stool. So collecting a stool sample, not fun, but necessary. And when you can get it and have it cultured up, you can get a lot of information about what could be causing the diarrhea that's happening. In terms of GERD and esophagitis, it's the passage of gastric contents into the esophagus, and you're going to see these types of symptoms. So vomiting, weight loss, heartburn, chest pain, difficulty swallowing, or feeding refusal. Sometimes with wheezing, you'll see that too, related to GERD, or noisy breathing. Hoarseness of the voice is another clue to gastroesophageal reflux. Cough, chronic cough, is also another clue. And then the abnormal neck posturing and arching. Arching is what you see in babies when they have gastroesophageal reflux disease. They'll physically just arch their back. And that's kind of a sign that this is reflux. But in older kids who have autism spectrum disorder who may be nonverbal, they might be stretching their neck periodically. And that's one way to try to get the contents back down, right, and not cause the burning. And so the typical foods that cause reflux, things like caffeine, right? So coffee too, with or without caffeine, can relax the lower esophageal sphincter, lead to reflux. Foods that have high acidity, carbonated beverages, not foods. So think about when you're drinking a soda, there's gas in it, right? CO2. The gas increases the belly, creates what we call abdominal distension. That increases pressure on the lower esophageal sphincter, and then that creates more reflux back up. So if you're having somebody who's drinking lots and lots of soda, they're going to be more and more at risk for things like reflux, okay? Chocolate contains methylxanthine that's similar to caffeine. That can also cause things like reflux. Peppermint, garlic, onions, they all relax this lower esophageal sphincter that can also cause you to have reflux. And then fatty, spicy, fried foods. The way that works is it delays stomach emptying. So food stays longer in the stomach, and so that obviously increases the lower esophageal sphincter, and then that causes reflux back up. So this is all true for adults too, right, who don't have autism spectrum disorder. All these foods do the same thing in adults as well. And then the other thing is around feeding challenges and overweight. And so it's usually multifactorial. Medications are a culprit, especially the atypical antipsychotic medications. Risperidone is one of the common ones. that can cause that. Sometimes with the SSRIs, you get weight gain from eating more. You can also get weight loss from eating less. So it's all dependent on how one reacts to the medication. Sometimes it's the rigidity with the diet, and then mental health related comorbidities, anxiety, and anxieties around food. And so lack of exercise. And some examples that we see, or come in for clinic, that I see are things like diet rigidity, where a child has to have 10 chicken nuggets in the morning, 10 chicken nuggets at lunch. It has to be 10. Can't be 9, can't be 8, can't be 11, can't be 12, has to be 10, right? And then 10 chicken nuggets for dinner, right? So all of that creates a lot of calories that then leads to significant weight gain, and obviously then there might be less exercise, so you don't have time to burn off all of those 10 chicken nuggets. There's also anxiety around feeding and anxiety around food that leads to overeating. And so usually what we'll try with that is things like behavioral therapy. So someone who can participate in cognitive behavioral therapy, they'll work with a therapist to talk about the anxieties around food and then work on strategies. In other cases, if there's like larger challenges with anxiety, we'll think about using a serotonin reuptake inhibitor, something like Zoloft or Prozac as well. And then lack of exercise. And so I talk a lot about the importance of exercise, not just because of cardiovascular health and getting your heart rate up, but it's also important to get out of the house, right? Time outside of the house decreases time near food, right? Time outside the house gives new opportunities to participate in the community, to be at the park, to be with peers, to be, at an event. Those are all important aspects of exercise because you're walking and you're outside and you're burning calories. And so those are all kind of the same approaches as we do with kids who are typically developing, who also have challenges with overweight. You want to make sure you screen for other comorbidities. So a child who's overweight, if you can get a blood sample, you want to look at cholesterol, you want to look at triglyceride levels, you want to look at HDL, LDL, and things like that. You also want to look at hemoglobin A1C, looking for prediabetes, diabetes as well. And so we're in this new era now where we're actually using, we used metformin before, now we're starting to use Ozempic and GLP-1 agonists as well. There's some other medications that we sometimes will try, something called phentermine, which is more like a stimulant that decreases appetite. We use the combination of topiramate, which is actually an anticonvulsant, with phentermine, and that also decreases appetite as well. So I have several patients who are on the spectrum, who are adolescents, who are on Ozempic, and what we're starting to see is obviously some weight loss, which is great, because these are folks that aren't just a little bit heavy, they're a lot heavy. And but the other thing we're starting to hear more and more about, and I've talked to others over the course of this week about this, is this idea that parents are now reporting, because we ask, how are they doing around behaviors, and how are they doing around behaviors around food? And some of the reports we're starting to get back, and we're going to be, we're trying to study this when I get back home in a larger data set, is that we're starting to hear that there's less anxiety around food, and their behaviors in the day are actually better, and they're not thinking about food all the time. So it's working exactly the way it works in folks who don't have autism spectrum disease, right? Because when you talk to adults who are on these GLP-1 agonists, they'll tell you they don't crave food as much. They'll eat, but they don't crave, and they're not thinking about food. And then in the adult world, we hear more about, like, they don't crave alcohol, they don't crave smoking anymore, things like that. And so, so we'll see where this goes. But this is available, and it's available to kids 12 and above, where the behavior interventions haven't worked out, and it's something else to think about if you can get it. Yes, question. GLP-1 agonist, and that's the brand, the common name is Ozempic, right? And there's a bunch of different name brands that you can use, right? Wegovy is one that's common, but the scientific term, chemical term is semaglutide. Semaglutide, or Ozempic. And your doctor probably knows all about this too, right? The feeding challenges that we see, food selectivity, again, multifactorial. So sensory processing is common in autism spectrum disorder. And so you can imagine that it can also affect feeding, right? There could be texture aversion, so there might be preference or avoidance to crunchy foods, mushy foods, mixed foods. Could lead to an overreaction to certain smells, certain taste intensities, and also visual appearance of the food could also impact that food selectivity. And so it could be color, it could be shape, it could be arrangement, right? And we often hear the food can't touch. And that's something we see also in kids who are not on the spectrum but who have significant anxiety issues. Food can't touch, right? There are some behavioral factors too, rigidity and routine, and escape maintained behavior, so that refusal is reinforced when mealtime ends early or attention is given to that, and then that reinforces kind of the behaviors. And so you're thinking about the reinforcement history, so food refusal that leads to preferred foods, right? These kids are smart, they can figure it out. If I refuse, I wait it out, I'll get what I want. And then that creates that repetition of the only food. Or it could be used to get attention from the parent as well. And the parents will accommodate typically, right? And so you're trying to help your child and do what's best for them. On the medical side, what we see too with food selectivity is they might avoid certain foods that causes reflux or constipation that they know and they've developed over time, or food allergies. There's some cultural practices that lead to food selectivity, so food choices are shaped by the home environment. Sometimes food selectivity is shaped by early feeding experiences, and sometimes previous choking episodes or vomiting or force feeding leads to traumatic experiences that then leads to certain food aversions as well. And so when you're thinking about things like food selectivity, thinking back to, was there a time when there was trauma? Was there a time when they went to the dental office and they're being held in a chair and somebody's opening their mouth and putting things in, and then it was time to go to, get a bite to eat, and then they all of a sudden refused, and now they're no longer going to eat that type of food anymore, right? It's the associations to the trauma that then lead to that food selectivity as well. And then delayed introduction of textures in very early childhood seems to also lead to food selectivity later on. And so when we're working with new parents or even parents who've had their second, third child, it's also in that first year when you're doing solids, it's just mixing up textures so that the baby starts to experience, crunchy, mushy, mixed, things like that to get their sensory sensitivities lessened. So the approach, there's a medical approach as well as a nutritional evaluation. You want to rule out all of those gastro kinds of etiologies like reflux, constipation, nutrient deficiencies. We want to do a feeding history. So what we're going to want to hear is kind of the food variety and then the patterns for refusal of food to give us a sense of, is this texture related? And then we also want to hear about mealtime behaviors. What happens at mealtime? What's the process? What's the routine? And we want to hear more about that to kind of help with that food selectivity. And we want to identify whether food selectivity is based on type. So is it only white foods? Is it only brown foods? We want to know if this is related to texture. So is it avoiding crunchy foods, mushy foods? Or is there brand or routine dependence? And a quick note about brand dependence. Brand dependence really starts to emerge when, and the reason why it emerges is that kids who are on the spectrum, they know exactly what, for example, McDonald's, right? McDonald's fries. It doesn't matter where you are in this world, McDonald's fries taste the same. And that's why they go with McDonald's fries only, right? Or, chicken nuggets from McDonald's, because they taste the same everywhere. And that's what leads to more of that food selectivity, because they don't have to worry that this is going to taste differently now. And so that's why when we hear like, hey, he has fries, he only likes it at McDonald's, but when I try to bring home the Ore-Ida, put it in the oven, he won't touch it because it tastes different. The texture is a little different. But you got to keep trying, and you try to keep introducing foods, new foods, letting them play with the foods, letting them tolerate the presence of a food first, and then eventually you move that kind of non-preferred food closer to the food that they prefer until they can tolerate that. It sounds almost like very laborious. It is. It takes a long time to introduce one new food until the point where they can touch it. And when they can touch it, then you try to move to, can they smell it? And will they tolerate the smell? And then you move to, can they just tolerate the touch of the new food on their lip? And if they can start to do that, then you might even move to, can they tolerate putting it in their mouth without necessarily taking a bite? And then when they can tolerate putting it in their mouth, can they tolerate taking a bite? If they can do that, you're not forcing them to swallow. Obviously, throughout all these steps, you're rewarding, you're celebrating, great job. And eventually, they'll take the bite and they'll swallow it, and they actually might like it. And then that's how they develop the taste. But it's not going to be an overnight thing. It's not going to be a day. It's not going to be a week. It's going to be weeks of this, okay? And it's not going to happen for every food, right? Because once you get to one new food, it sometimes gets easier to do the next one in the same process, and that process might actually get a little faster. And so it's patience with this, and it's also setting some realistic goals and following up. So the other types of interventions is behavioral therapy, that's ABA, it's reinforcement, it's shaping, it's parent training and mealtime structuring. And so what we're trying to do very early on in a child's life is limit the short order cooking that parents have to deal with, okay? And establishing consistent routines around the dinner table, and setting expectations very, very early on about behavior at the dinner table, what the table is there for, which is really to come together, to break bread, to eat together, to communicate with one another, and to socialize with one another. That's the value. And so when we hear a lot about kids who are on the spectrum, they take their food, they run off into the living room, and they plop themselves in the front of the TV, and they'll eat. And parents are really happy because they're eating, right? And that's a great thing. But what it reinforces is the behavior of eating is not with the rest of the family, where the rest of the family is trying new foods, sharing their day, interacting, things like that. So we want to kind of move it back to, hey, the living room is there to watch TV. The family room or your kitchen where the table is where we eat, and that's where the food will be. And you want to start that very, very early on in a child's life. So that just becomes the new routine, right? And it's establishing new routines all the time. Sensory integration therapy can help with the textures, so it's addressing texture, taste, and working on these non-preferred foods. A lot of feeding evaluation and feeding therapy is team-based, and so you're looking typically at either an occupational therapist with a nutritionist, and sometimes with a mental health professional as well, and then coming up with a plan around introducing new foods. And so the nutrition piece of a nutritionist is really correcting any kind of suspected deficiencies in minerals or vitamins and things like that. And so let's see if I'm hoping this works. So this is an example of an intervention. Oh, here we go. Okay.
It's a bear.
So there's a mother, a child, therapist, and this is feeding therapy. And they're trying to introduce
Okay, you know what, George?
a cracker.
I'm gonna bite.
So she says, I'm going to bite his ear.
Got his ear. Look.
Make it a game. It's funny, laughing, right? It's all good.
Look at this one. I'm gonna look.
All right, so we're going to advance it a little bit. Now I'm going to try to make you try this and look at the reaction, right? Resistance, crying, everybody's crying. So the therapist says, hey, don't give it attention. Turn away, let him have his cry, let it settle, okay? Keep supporting. They're talking to one another, child's crying, right? He's waiting. All right, stopped.
Even that to him is like a special touch. He knows, that you're there.
So they're talking, and the therapist is supporting the mother.
Okay.
So then watch what happens. It's coming
All done,
back.
Right? Are you finished? Okay.
So
use
he's
your
got
words.
echolalia. Are you finished? Are you finished? Okay. So still a little bit of whining there, right?
Okay. Let's clean up.
So we're going to transition to a different activity. It's cleaning up. So he's thinking this is now
Can you
over.
bring this to the kitchen? 2 hands.
So they want him to now clean up.
You want to eat? Oh, okay.
So clearly he doesn't want to clean up either, right? So he's given another option. You want to try to eat. And then that's what starts to change the motivation. And then that's what causes him to now try the cracker. And then a celebration starts, okay? So it's that rigidity of behavior that you see in ASD, and it's trying to flip the script a little bit to make it their idea to try, if that makes sense, okay? And you can do that with not just feeding, but other things like behavior, right? If you're having a maladaptive behavior, it's flipping the script to getting them to do the behavior that you want them to do. On the physical health side too, neurologic conditions and concerns. Yes?
When you did that, was that with a non-verbal or no verbal child?
That child was nonverbal. But in the sense that they have echolalia, so they are verbal. They're able to make words and sounds, right, and repeat, but they're not using the words in that verbal sense of communication. Okay? And so so you could still do that same approach with kids who are nonverbal.
Okay, so let's say because I'm a parent without autism, I only work in the school with a child that's autistic. So let's say if I'm going to work from them from a school point of view, how can I do that?
Can you make it louder?
Yeah.
Make your question louder.
Okay, so I'm a parent that with a child with disability, but my child is not autistic. But I work in the school with a child who has autism and she's not verbal. How can I do that in the school setting?
So are you talking about feeding in the school setting?
And feeding in the school setting because the child is.
So I'm having a hard time understanding the question. What? Oh, so picky eating is a different kind of thing. And so, working on picky eating, it goes back to that whole idea around chaining, right? Where you're introducing new foods, not for them to eat, but to introduce new foods to put on their plate, to tolerate the presence of a new food. And then you slowly move that new food next to the food that they're eating. And then what you're doing in that time period is also encouraging for them to play with the new food, touch the food, right? They don't have to eat it, they just need to be able to tolerate it. And then when they're able to tolerate it, tolerate the presence, and they're able to touch it, you can ask them to pick it up and put it to their lip. Not to try it, you don't have to say you want them to try it or you want them to eat it, but just put it to their lip to see if they can tolerate that. And if they can tolerate that, then you go to the next step. Will they lick it, right? And that'll give them the taste. Will they tolerate that? And you keep doing that with that one food until they actually take a bite. Does that make sense? So it's a whole process of chaining, and if you have an occupational therapist that works on feeding, they can talk to you about that whole process as well, okay? But it's a slow process, and it's, again, it's introducing new foods, right? But you don't want to introduce like 5 new foods. You want to introduce 1 new food. and then one at a time and go slow, okay? Yes?
And I was just gonna add that what I find helpful, like for my own kid who was very selective in eating, was that you kind of want to choose a food that looks similar to a new food that looks similar. Like start with using a new food that looks similar to the food that he likes. So, like if he likes spam, because a lot of people don't want like spam, you would put ham instead. You know, like the new food would be ham, which looks a little bit alike this in color, but like what Dr. Green said, like don't say, we're so always like, don't play with your food, don't play with it, but you want them to play with the food. You want them to have that time to like touch it, lick it, and it's okay.
Mm-hmm. Absolutely, and the idea around picking foods that might look similar to what they like, the only risk to that is if they don't like it, they may not like the other food that they used to like, right? Because of the association. So you just have to think about, how you want to approach this. And so there's, you try different things is the key. And then you keep trying. Yes?
My question is, for the school aid to do it at school, it needs continuation at home, so this is something
That is correct.
this is something that needs to be discussed with the parents first, I think, that we're gonna do this, we heard that it might work. Can you do it at home, or do you agree that we're gonna do this? Because it may cause a behavior at home.
That is such an important point, right? You got to have the parent buy-in. So if this is written in the IEP that you're going to work with this, okay, fine, right? Because then the parents sign the IEP, they agree, whatever. But you definitely want to have the parent buy-in. And you also want to hear from the parent what works at home, right? So that you can also use that in the school. Because ultimately what you want is whatever you do at school, you want that to happen at home, right? For trying to treat these types of things in terms of behavior, okay? And so never in isolation, it has to be in multiple settings, right? And so if you can show that a child can perform or change their behavior in one setting, it doesn't mean they'll just do it automatically at home. You've got to work on that same behavior in the new environment as well, okay? And so that's part of what's unique to autism spectrum disorder, is that kids who can do things in one setting don't always do it in all settings. That's that rigidity. And if you could kind of work with that rigidity to try to make that less stringent, then you're going to see more typical behavior, right? And that's the goal with some of this, some of the interventions in the interventional approach. Neurologic concerns, epilepsy, seizures, it's high, almost up to 50% in some studies. You got to evaluate, you got to treat. It's the same as somebody who doesn't have ASD. We typically will do an EEG or a prolonged EEG with video. And an EEG is where nowadays you wear a cap and it's got the wires attached and it's just looking at your brain waves, right? And you're attached to that, and it gives you a sense of how the brain waves are working. There's a lot of kids who have atypical, and I wrote abnormal here, but EEG findings, but they don't have clinical epilepsy. Nobody really knows how to manage those types of kids. And so we definitely know how to manage kids who have spike wave patterns that are consistent with complex partial seizures, generalized seizures, things like that, and the medications that go along with it. But a lot of times you'll get a report back that says, oh, there's generalized slowing of the EEG. We don't really do much with that, okay? And so it's more, with more time, and more research, we'll have some better options for folks as well. The things to know around seizures and for parents to know is changes in behavior. You're seeing new repetitive body movements, right? Or you have periods of these unexplained periods of fatigue or weakness, or periods, the common thing is we hear staring off, right? Or being non-responsive to voice or people. And it's really the importance of, everybody stares off every once in a while, but it's the staring off where they're just like not connected to you at all for more than 10 seconds, 20 seconds, things like that. Or they feel tired after staring off. That's more consistent with a potential seizure event. The challenges with the diagnosis of seizures is not all body movements are seizure related. So you might flap your hands, but that might not be a seizure, right? It's the combination of flapping your hands and then being tired afterwards, okay? Or flapping one hand first that then leads to flapping of another hand and then shaking of the head and eyes rolling back. That's more consistent with the seizure rather than just flapping, right? And then the strategies that can help is obviously thorough history from you, thinking about what happened before the event. Was there periods of stress? Were they not sleeping the night before? Were they sick? Those are all things that make seizures come out, okay, if they're there. And can you make the shaking stop? And so if you put your hand on somebody who's shaking their arm and it stops, not a seizure, okay? If you put your hand on them and your hand is shaking, that could be a seizure. The eye fluttering, the eye deviation, when the eyes start deviating, they flutter up and down. Those are all consistent with seizures too, during an event. And then the other, we talked about fatigue, but also confusion. They seem confused after this. That's a clue into, could this be a seizure? And then the thing that's really helpful is video, and taking video of the event if you can, catching it on camera, and then bringing it in to the doc to show this is what happens. So many kids get diagnosed at the start just based on a video, okay, of a seizure event. All right, sleep. I know we got a lot of reviews from last night. They want to know about more sleep and sleep hygiene. Exact cause, nobody knows, right? But it's highly prevalent. 40 to 80% of kids who are on the spectrum have a sleep disturbance compared to only a third that do not have ASD. And there are different types of sleep disturbance. So it's delayed sleep onset. So kids who go to bed late, can't fall asleep early. Kids who have night awakening, right? So they can fall asleep, but then they wake up in the middle of the night. Or early awakening, and then they'll wake up at 3 a.m. and then stay up, right? They go to bed at 9, they wake up at 3, and then they're up the rest of the day. Or they go to bed at 1, wake up at 3, and then they're up all day. You know as well as I do that this creates a huge impact to life, quality of life for families, right? But it also impacts behavior of the child too, okay? And so the causes of some of this, obstructive sleep apnea, that's like the snoring, right, that you might hear. Or you'll hear kids who wake up in the middle of the night gasping for air because they can't breathe, right? That's obstructive sleep apnea. That needs to be evaluated. Tends to be higher in kids with ASD, but it's a strong association to their body mass index and their weight. Okay? What we usually hear about kids who have obstructive sleep apnea is they don't sleep flat on the bed. They have to have pillows, and they have to sleep upright, and they have to keep their mouth open while they're sleeping so that they can breathe. Okay? And so those are all clues into maybe this is obstructive sleep apnea, etc. Circadian rhythm disturbance. There are some kids, their circadian rhythm is just off. They're up at night, they sleep during the day, right? And then that's a whole different approach to trying to get their circadian rhythm back to the typical night-day cycle, okay? GERD creates problems because they'll be sleeping, reflux comes up, they have burning, they wake up, gasping for breath, now they're up. Now they'll stay up, okay? Melatonin production, there's multiple studies from the 1990s that demonstrate that some kids with ASD have lower melatonin production. And so sometimes they need more melatonin to help them sleep. The other thing that we try to do with melatonin and melatonin production is really bright light therapy in the morning. And so the first thing in the morning, you gotta have at least an hour of bright light to reset the brain in making melatonin, so that the brain gets reset to day and night cycles as well. ADHD, anxiety are also things that keep people up at night, whether you have autism or you don't have autism, okay? But a lot of the sleep patterns that happen in ASD is really behavioral. Okay, sleep onset association. They associate sleep with something, nighttime with something, and so they don't want to go to bed, right? The problem of limit setting around bedtime behavior creates another challenge as well. Using methods to calm the child so the child never learns how to calm themselves. They require somebody else to be there. That also leads to future sleep problems, right? It's that ability to be able to calm yourself without the help of others, because when all of us wake up in the middle of the night, we're able to usually go back to sleep because we're usually able to self-calm, right? A child who's never been able to self-calm can't go back to sleep, so they stay up. And so it's trying to teach that self-calming, self-soothing very early on, reassurance that you're going to be there, and then once they get drowsy, then leaving, so that they've been able to then kind of go back to sleep on their own. And then screen time use. I'm sure you all know with screens, you have blue light. Blue light stimulates the brain to stay awake, okay? And so if you have a child who's calms with the screen, I get it, you want to give them the screen, but you want to turn off the backlight, the blue light. They're not going to like it because it's going to look yellowish on the screen, but at least you're decreasing the amount of blue light stimulation that they have. If you can get away with turning off all electronics 2 hours before bedtime, that's ideal, right? And if you can make it 3, even better, okay? Because you're trying to decrease the amount of stimulation before bedtime. So you don't want nighttime to really be like, it's fun time, we're going to be playing video games, we're going to roughhouse, we're going to chase you around the house and get you amped up, and then you say, okay, it's 10 o'clock, it's time to go to bed. It doesn't work, right? You want to make it really kind of boring, no movies at night, things like that, and just really calm environments, right, so that they can fall asleep. Okay. Evaluation around sleep, usually it's a sleep history, looking at the sleep environment, and then a sleep study. The sleep studies help with figuring out, is this obstructive sleep apnea? Maybe they have obstructive sleep apnea, their oxygen levels are dropping low, and they need oxygen at night to help them sleep, or they need a CPAP machine to help them get air in. And so when you hear from folks who finally get diagnosed with obstructive sleep apnea, they end up having obstructive sleep apnea, they get the BiPAP machine or the CPAP machine, and they are able to wear it, they come back and tell you what a great night of sleep they had, right? The challenge in kids who have autism spectrum disorder is, will they wear the mask? And you can usually have a therapist work with them on desensitizing them to accept the mask so that they can ultimately wear it, okay? Some medications that you can try, obviously melatonin. There are other medications that we try too when melatonin isn't as effective. And we'll use things like something called alpha agonists. The common name is guanfacine or clonidine. We'll sometimes use that. We'll use antihistamines like the Benadryl that you use for allergies, if that makes your child more drowsy. Okay, so just know that for some kids, when they get Benadryl, it makes them more hyperactive, and then you just want to stay away from that. There's also something called hydroxyzine. It hits both of the receptors, and so sometimes that helps as well. And then it moves into other medications that you can try, but that's obviously with your doctor and talking about other medications. And the other medications are really trying to use those to address other kind of mental behavioral health conditions that might be present as well. And so, so that's the physical, but there's also the behavioral and the mental health things that can also occur in kids who are on the spectrum. So we learn more and more each day regarding kind of the behavioral challenges seen in ASD, and many of these behaviors may be tied actually to an underlying mental health condition. And so things like anxiety, ADHD, depression, aggression, and disruptive behaviors are also all the things that we also see. And so the reason why it's hard to pick up is, again, challenges in the diagnosis, right? The tools we use that to assess for things like anxiety, depression, they weren't designed for kids who are on the spectrum, right? They're designed for kids who are typically developing. And then the communication challenge. It's very hard to have a child who's verbal with ASD to tell you, I'm depressed or I'm anxious, right? You have to get to it a different way. And then behavior challenges too that you see that might be new, that actually might be related to anxiety and not the autism. Or it might be related to depression and not the autism. Or it might be related to ADHD and not the autism. So it's thinking about things like that. The approach to the evaluation is you're looking for symptoms that are above expected given the developmental level, right? And so each child has a developmental level they're at, and is their behavior consistent with that developmental level, or is it really way out of bounds, right? That. Do the symptoms cause functional impairments? So does these behaviors keep them from participating in regular day-to-day life, right? Or is it becoming a barrier for them to participate? And then, do these symptoms exceed typical response to the challenges that you might see in ASD? And then we always start with, has there been any changes at home? Any changes in the environment? Any new people visiting the home? Any new caretakers? Any new therapists? Or is it a new home that you just moved into? Those are all things to kind of just start to think about on your end when you're seeing new behaviors kind of emerge. And so for anxiety disorders are characterized by excessive fear and or anxiety, which leads to impairment and or distress. That includes disorders like separation anxiety, right? They get worked up if you leave, okay? A specific fear of, spiders, or specific fear of dogs or cats or things like that, specific phobias. Social anxiety, not wanting to be in crowds, not tolerating crowds. So it often gets, we also gets confused with, they just don't like the noise. Well, they don't like the noise because they don't like the crowds that come, that develop, that create all the noise. There's panic disorder, things where they're physically sweating, right, in a certain situation. Those all point you towards more of like an anxiety, or fearful of being in a small space, right? Things like that. All kind of point to, could this be anxiety? The atypical symptoms, like influences of worry related to preoccupations, phobias, kind of an intense focus of ideas, or compulsions, like this need. I was hearing, we were talking to somebody earlier, this need to wash all the dishes, even though it's dinner time. And we can't get back to the table until every dish is washed. Well, that's an obsessive behavior. That's not autism, okay? That's not rigidity. It could be a rigidity, but it's the idea that I have to do it all before I can get to the next activity, right? That's what makes this more of an obsession, and then as well as a compulsion. I gotta wash the dishes too, okay? The other things would be, like we talked about, separation from a parent, could reflect the separation versus resistance to change. So that's why you're trying to figure out, is this the autism piece or is this really anxiety? Another example might be that is this an obsession, a compulsion, could be related to the pleasure and restricted interest versus distress when specific activities are not carried out. Does that make sense? And so if something's not being carried out, that's an obsession that has to happen, right? Versus really just, I just enjoy this and I want to do it all the time, all the time, all the time. Another example, repetitive questions could be related to trying to learn about a specific topic versus the repetitive questions driven by reassurance. Got to know this, so I'm going to keep asking the same question over and over again. That's more of an obsession, right, with getting the answer. And then the externalizing behaviors can be triggered by sensitivity to change, challenges reading the social cues, and that's social anxiety, and then some cognitive rigidity as well. And when we talk about externalizing behaviors, what we're really saying is kids who really kind of turn outwards with their behaviors. They get upset, they hit, they get aggressive, they yell, they flap, things like that. Versus internalizing behaviors, you can have internalizing behaviors with anxiety where you just kind of shut down. You get quiet, you move into yourself, right? And so that's also anxiety as well. And so, we're trying to think about things like this as well. And then what I have there is a couple of scales around anxiety that were specifically designed for the ASD population that you can use, or your provider can use, and then you look at it, you score it, and you figure it out. But again, it's just really patterned off of the existing screeners we use for anxiety. Treatment, it's usually, we always talk about therapy first, therapy first, therapy first. If your child can participate in cognitive behavioral therapy, usually the youngest ages are around 8, and 8 years old, participating in cognitive behavioral therapy. And it seems to have some benefit for treating anxiety better than most other therapies, okay? And medications can also help. It can also be a bridge. In LA, there's a lack of therapists for cognitive behavioral therapy, and so some kids wait a year to get into therapy, and so things get worse over time, right? And so we offer medication support to try to create a bridge to that before they get into therapy as well. And it's the same medications. When it works, it works. When it doesn't work, it doesn't work. We don't know why, right? And so we need more research to understand what are some of the reasons, what are the kind of key ingredients to make these kinds of things work. But we do know that the kids who truly have anxiety typically will respond to medication support too. And you'll probably read in the coming year the trial that was done at CHLA where we're comparing kids typically developing, different guy tonight, right? This is cool. I know, right? Comparing if you treat a child with therapy first versus medication first, who does better? And you look at it over 6 months. And then the kids who got therapy first, and then after 6 months they got medication second, did they do better? And so you'll probably read, there will be a study that will get published soon about that trial. And it'll kind of guide how we manage anxiety as well. Hey, how are you? I know, you're good. All right, and so moving on to a different kind of condition. This is a talk I do for a lot of docs. So patient comes to the room, this is what it looks like. Yes, this is what it looks like after your child leaves, right? This could be at your house too, by the way, right? You clean up, gets home from school, and this is what it looks like now. This is like the classic example of ADHD, okay? And in ADHD, the prevalence is high in kids who have autism. And first, the first point is that kids who are minimally verbal with ASD are more likely to experience symptoms of hyperactivity, higher severity of these symptoms, and meet clinical cutoff criteria for ADHD as well, compared to verbally capable kids with ASD. The second point is gender may influence the likelihood of a dual diagnosis, meaning a co-occurring condition. Males are more likely to be diagnosed with ASD. Males are also more likely to be diagnosed with ADHD than girls. Doesn't mean that boys have it more often. It means that girls get missed with ADHD. They actually they may not have the hyperactivity component. They may have the attention component of ADHD. So they get missed in a classroom, right? Because they're not moving, they're not getting out of their chair, they're sitting, but they're having a hard time paying attention, okay? And so that's why a lot of these girls with ASD get missed with ADHD. And then that was my second point. And third point is we know that there's executive functioning challenges in both ASD and ADHD. And the cognitive profile of kids with ASD and ADHD it consists of impaired working memory. And so like when you do your triennial evaluations, they do testing. And you might see working memory as a component of the testing. And we look at how is that working memory doing. And if it's very poor or low, that tells you that they're not able to keep the information in their head for very long. And that points you more towards things like ADHD, inattention, okay, and challenges with focusing. And then fourth, age is an important factor too. So typically ADHD gets diagnosed much later than ASD. ASD now is, we typically on average see by age 4. ADHD we typically diagnose by age 6. Okay, and so it's like really trying to figure out, is this a co-occurring condition, is this or is this really autism related or not? The challenges in the diagnosis is all of the symptom overlap between a restrictive repetitive behavior in ASD and impulsive behavior in ADHD. And so a lot of times we'll look at behaviors and they really sound more like impulsivity. They just can't hold back, right? And then they do something. And that kind of helps us think about maybe this is ADHD, and then do we try to do something about that? And there's really no available measures right now that really differentiate between ADHD behavior and ASD behavior. And so it's really about clinical experience, the context of the events that occur to kind of really drive how you think about this. Parent training is kind of where we start with ADHD, okay? And that treatment is similar to patients without ASD. And that's where you take a course, basically, in how to manage ADHD type symptoms. And so the typical approach in a child who's having difficulty with focus, concentration, hyperactivity is decreasing distraction, right? So if it's homework time, you really want the homework time space to not be in front of the TV, to not be by a window, to have a desk, to have a chair, and really kind of a blank wall, right? Where they can't. And the other important piece of this is time. You can't expect them to sit for 10, 15 minutes in a chair doing activity. It's more like, can you do 5 minutes of one or two problems, and then let's take a break. And that break is, let's go run around, let's go jump on a trampoline, let's go do something physical for 5 minutes, 10 minutes, and then come back. And we're gonna do another 5 minutes in the chair on the pencil activity, right? And then you go from there. Homework takes a long time. That's why in IEPs we say, look, if they can figure out how to do the problem, they don't need to do 20 of the same problem. They can do every other, every third, whatever. The medications we typically use in ADHD, no different than in kids with ASD, and it's typically stimulant medication or non-stimulant medication, which is the guanfacine, clonidine, or atomoxetine. And the efficacy of the medications, all the studies show right now that medication alone is better than therapy, okay? Medication with therapy seems to be a little bit better, but not much. It seems to be that medication seems to be the thing that works, okay, the best around ADHD. And I think, and obviously this is a parent decision to make, right? This is where you work with your doctor to really have shared decision making about the pros and the cons of medication, the beliefs about medication. But the important point that needs to be said is that medication is not forever. Medication for ADHD is not meant to go years and years and years and years. Medication in ADHD is really to support the child right then so they learn how to organize themselves. They learn the expectations of learning, and then they learn how to get themselves organized independently so that they don't need to be on medication. And if you look at studies, the longest period of time kids on average are on medication is about 1.5 years, okay? Because usually they just stop them, parents stop them, et cetera, et cetera. And I think the common thing we hear is parent concerns about, well, if we use medications, especially stimulant medications, they're going to be more prone to drug use later. They're going to be addicted. And the reality is, from research, is that the kids, when you look at kids who got treated with medication for their ADHD, and you follow them out to adulthood, and you compare them to a group of kids with ADHD who did not get medication and grew up in adulthood, the kids who grew up without medication support with ADHD had a higher rate of using substances as adults. so self-medication, compared to the group that actually were using ADHD drugs, right, to manage. And so, you know, for some kids, it's a game changer. For some kids, it helps smooth things out so they can participate. And when you think about kids who are on the spectrum, life is hard enough following a conversation. You add on a layer of ADHD where the life, it's going so fast, right? So they're having a hard time staying with the conversation because of communication challenges, higher level thinking challenges, and then you add on the ADHD, and it makes it almost even more challenging. And it creates even more barrier to social interaction, things like that. With medication, at least they can slow down a little bit, and they can actually hear the conversation now, right? And so now it gives them an opportunity to participate in the discussion, in the classroom, and things like that. Depression is another condition that we see in kids. We might overlook depression in ASD because yes?
For medication for ADHD, ADD, should a parent go to a family doctor? Are they able to, or does it have to be like a neurologist?
So everybody does it differently everywhere, right? And so back home, I've been pushing our pediatricians to make the diagnosis and start medication and get them going, right? Because it doesn't make sense to me to wait a year to get in to see a neurologist, right? The beauty of, well, I shouldn't say the beauty, the advantage of medications like the stimulant medications is they're short acting. They don't stay in your system. The short acting stimulant medications last for about 4 hours and then it's gone. So what we do is when we consider medication and parents are reluctant or they're kind of on the fence, we say, you know, we'll start with the short acting, we'll start at the lowest dose. We always start at the lowest dose. And then you can see for yourself on a Saturday how does it do anything. And most of the time they'll say, no, it didn't do anything. And then we go up on the dose and then check in, did it do anything? And then once you start to hear like, no, oh my goodness, they slowed down. They're there, they're participating, things like that, then we know we're on the right dose, okay? And so it's a process. It's not like antibiotics where you can just write a prescription, take this for 10 days, and things get better. Sometimes you have to try different classes of medication too. So one medication may not work. And so the usual approach is you start at the lowest dose, you go up until you find out like it's not doing anything, and then you switch over to a different class, start at the lowest dose, go up until you start to get the behaviors that you're looking for. And the way you look for it is you fill out these surveys. How's the behavior? And so you can see quantitatively, is the behavior getting better, right? It gives you more objective measures. So in some places, your family practitioner can do it. A lot of them don't feel comfortable. In some places, the pediatrician can do it. Sometimes they don't feel comfortable. In other places, the neurologist can do it. Psychiatrists can do it too. But you know, there's long wait lists for all of the specialists. And so that's why we've been really pushing on our group to really start it and manage it. And for the most part, it's been doing, we've been doing quite well. We've been able to kind of help folks out, right? The goal is not, I know there's a lot of literature out there. There's a lot of things on the internet. You just have to be careful about what you read. You have to, really understand kind of the pros and the cons of medication. And these are family choices, and that's, and that's fine. But for kids who truly have ADHD, medication can be helpful to their learning. And when you talk to parents that have kids with ADHD where medication has worked, they will tell you. They're not going to be loud about it because, they don't want to be, called out or things like that. But it does work, and there's plenty of data to suggest that it actually is something more preferable for things like controlling attention, focus, hyperactivity. The other challenges of why depression gets overlooked in ASD is that we think about self-isolation as part of ASD, right? But it also is part of depression, and so you want to look into that. Sleep difficulties can also be associated with depression. Atypical affect can be also viewed with depression, and then that cognitive rigidity is also sometimes associated with depression as well. And so it's that those are the challenges in trying to diagnose, okay? And then the approach, it's evaluation, and it's challenging. There's no ASD-specific measure to help in the diagnosis of a child who has both ASD and depression. But you want to use a framework that emphasizes behavior change that are different from the characteristic behaviors in ASD. We want to hear about the history of anything predisposing that could have caused some of this to happen. And do the symptoms really represent a clear change in the baseline functioning. And then, unfortunately, suicidality is another important kind of risk to screen for depression in the population. And we do see that in older kids. The treatment's the same. Cognitive behavioral therapy is helpful for depression, as well as medication as well. And then the irritability, the self-injurious behavior, the aggression, it's as high as 85% in a lot of studies. The presentation also varies. It's typically a consistent pattern of behavior where it becomes problematic. Sometimes it's also inconsistent, so that makes it harder to really identify what happens before it's the trigger, and then it can overlap with other conditions. Usually what you might see with irritability and self-injurious behavior is there's been a change in the environment, things like that. But it does create major challenges in quality of life for these kids. So it's school participation, right? So if you have a child who has aggression, things like that, it's harder to participate in school. And it causes a lot of parent distress, right? When there's issues around hitting. And we deal with a lot of families who really have challenges because they live in an apartment and they're so fearful of getting evicted because of all of the noise and things like that. And it's really kind of challenging to try to help families who are going through that. And sometimes, we'll resort to medication support for that as well. And so it's really kind of that, the issues around history that we're looking for. And I'll give you an example. I have a patient who's a teenager with ASD who's nonverbal. And he hits his parent for no reason, right? Will throw dishes behind the cabinet and literally break dishes at night. And so part of that evaluation is this like learned? Is this an obsession? Like picking things up. He would like to pick things up off the ground and put it in his mouth. And compulsively, he would clear the table, push in all the chairs, right? And the trigger to hitting is that when he stopped, it would happen when he would be stopped from picking things up off the ground and putting it in his mouth. That's when he would start to hit. Or when he's trying to just clear the table, he would get more aggressive. And so, we tried to develop an alternative parenting strategy to really let him pick things up off the ground, right? And then transition that to, instead of putting it in your mouth, put it in a trash bag. We would have the parent bring in a trash bag. You could pick it up and you could put it in the bag. That seemed to help, right? That compulsion about clearing the table, we would actually help him try to transition him to a different thing where he would kind of clear the table by giving him another place to place the objects off the cabinet instead of behind the cabinet and throwing them on the ground. And so eventually he got to the idea of like, okay, you're letting me clear the table. I just won't throw them on the ground because there's no place to put them. I now have a place to set them. And that seemed to help with that behavior. So it's like thinking about like what's driving these behaviors, and that's kind of the stuff that we talked about last night as well. And that seemed to help as well. And then several months ago I got a call from the same family where he would be out with his parent and they're walking and he would just push other people aside. Like the person riding a bike, he would just push them off the bike for no reason. And so you're trying to think like, well, why would he do that? What is pushing him to do this? And it's this idea of like, he wanted to be on the road by himself. He didn't want anybody else out there. And so that's what led to that behavior. And so it's trying to then say, okay, you got to go to a place where they're not riding their bikes. You got to go to a place where you know that you'll be the only ones on the path, right? Or if you're going to see somebody else on the path, start to steer away to a different path. Okay. Treatments for irritability are typically atypical antipsychotics. That's the aripiprazole, the risperidone that we'll try. That's usually second line. We usually will try the alpha agonist, the clonidine, the guanfacine. We think that that helps with the aggression. And I really do think it's part of that impulsive behavior of aggression. So it's what we call impulsive aggression. And I think it's sometimes related to underlying ADHD. The SSRIs can also help because that might be anxiety, and now you're seeing the externalizing behavior of aggression. And acetylcysteine is a supplement that you can buy over the counter. There's some earlier studies that show that that might decrease irritability, but never really been replicated, but it's out there. And then usually when we get concerns from families about irritability, where we start is sleep. How is the sleep, and are they getting enough sleep? Because that's usually where we start, is trying to attack the sleep hygiene first before we start going to all these other things. Okay. So, conclusions. It's past 7, sorry. Co-occurring conditions in kids with ASD is challenging. It takes time to build relationships with families, and so it's really about kind of being part of that relationship and bringing in the information. The survey tools aren't always specifically designed for ASD, but the behaviors are similar, okay? And there's a challenge in interpreting these behaviors sometimes, and it takes some outside-the-box thinking around this. The prevalence of all these conditions are probably higher. We're just missing a lot of it, to be honest. And the approach has to be personalized. It has to be holistic. There's not a one-size-fits-all. And then really recognizing that these co-occurring conditions start in childhood, and they will persist into adulthood as well, especially if under-recognized. And then we need to find new ways to diagnose co-occurring conditions specific to kids with ASD, and that's what others are working on as well. And so, those are the types of co-occurring conditions we wanted to talk about. These are all the references from my talk, and we'll leave it there. And if you have any questions, please. We talked about a lot. I know there was a lot in there, and I know you have some notes, but just know that kids who have ASD do have other things that other typical kids experience as well. Yes?
You mentioned for ADHD medication, you said that ideally it should be like about a year, shouldn't be forever.
It shouldn't be forever.
It shouldn't. So is that the same for this treatment, these type of treatments for behavior?
Yep.
For aggression? And on average for like medication to address aggressive behavior, is it the same concept that is?
So we don't have enough data to actually show like how long people are on these meds for these like aggression and aggressive behaviors. But again, the goal is not to be on meds forever, right? The goal is to have therapy to learn like how to manage the behaviors, how to self-manage the behaviors. If it's taking yourself out of a situation, great, right? It's learning techniques to de-escalate a certain situation so that you can now self-manage.
And what are the side effects of medication that addresses aggressive behavior?
Typically, it's going to be appetite and overeating. They might get bigger, right? And so, it's really kind of setting the stage very early on around the importance around exercise, diet, movement, et cetera, for that, okay? But it doesn't happen to all kids. We have plenty of kids who are on these medications who don't gain weight, right? They grow typically.
Data to show children with ASD, what are like more combination of ADHD?
Right now, it's kind of like all over the map, right? And so you can have ADHD. What we know about ADHD is there's a strong anxiety component to ADHD. And sometimes it's hard to tell if this is ADHD or is this anxiety. And so often what we'll do is we'll start with treating one of the things, right? We'll start treating for ADHD, And what we're looking for is obviously the symptoms of attention and hyperactivity to get better. But if the anxiety gets better too, then we know it's more ADHD. If we treat for ADHD and the anxiety is really the main problem, then we know that it's probably more anxiety related, and we'll switch over to a medication for anxiety. Okay? And so there's no exact science to this. It's really about case by case and trying to understand kind of what are the behaviors and then how it fits into these potential diagnoses of either ADHD or anxiety, depression.
So that's where you came in and you said that after a period of time, they have a form that they fill out to track the behavior.
Yeah. So for ADHD, we use the Vanderbilt scales for ADHD. And, once you start a medication, you do the scale before you start medication, and then you repeat the scale 1 week after medication, or, it could be even a few days if you want to do that, to see if it's having any impact. But usually you use that tool along with what the caregiver has to say, right? And then you also try to get it from the teacher, what's happening in the classroom, and have them fill it out too. Okay. And you could do the same thing with the anxiety scales too, to measure has the anxieties improved, right? Have the perseverations around fires, floods, has that gotten better? Or the fear of somebody breaking into the house, has that gotten better? Or the need to turn off all the lights or close all the windows, has that gotten better with the medication support? Okay. We have to get out of the room? Okay. Any other questions? Yes?
Quick question. I wasn't sure, or I'm not sure if I missed it. Did you mention the age? Can you hear me?
Yeah.
The age at which you can start testing for ADHD?
Well, typically the average age of diagnosis is around 6, but it's usually present before 6, right? I mean, you could see it as early as like 3, right? We just choose not to use medication at 3. We usually want to wait, and we want to use behavioral interventions, and typically by 5, 6, we'll maybe try
That's when
medication.
you can introduce medication.
Right, but I will also tell you now we're moving towards, if there is really no improvement, even at the young age of 3, and you're sure this is ADHD, we will use medications in that case. And we typically will use either a stimulant medication or an alpha agonist.
Thank you.
Yep.
Can I just say something? Another thing is, I know that I always hear in the workshops, consult the teacher, which is true, but if I may add that, and for those who have an IC, also consider if your child has an age, give the age.
Absolutely. Oh,
You tend to
absolutely.
overlook the age. I think sometimes the age knows the child more than the teacher.
You're absolutely correct. You're absolutely correct. I was referring to like kids who don't have AIDS in the classroom, right? But to be honest with you, when we pass out these survey tools, we want as many people as possible, not just the teacher, not just the parent. We want, like, if there's a coach, if there's an auntie who does all the daycare, right, or the grandparent and the parent, because what we're looking for is consistency. Is there a pattern here? If things are only happening in one setting, that's not ADHD, right? If things are happening only with one person, that's not ADHD. You're looking for the pattern where it's happening in multiple settings with multiple people.
Yeah, I think when my son started medication, that's what the doctor did. He gave for the parents, for the other family members that help take care of him, but also 3 sets for 3 different teachers, just to see how he was progressing, if the meds were working, or, because what I see at home is going to be very different from what they see at school.
That's right. That's right.
And so we've been working with, so every month we go to the psychiatrist just to talk about, should we raise it, should we lower it?
That's right.
Yeah, getting everybody involved that's involved with him.
It's a process, right?
Yeah.
And so for kids who are already on medication and they're going to multiple classes throughout the day, The reason why we want to hear from each of those individuals and the time that they're having that class is to really understand how long the medication's effective. And is there a certain time period where the medication isn't effective? And you'll see that in the pattern, right? And then that helps you understand, do we need to increase the dose? Do we need to add a booster dose? Do we need to switch the medication with a different kind of profile of how it's released?
We have a student who has fixations on the same student's feet, to the point that he tried to remove the shoes, the socks, and tried to smell the feet. So we tried to do social stories, like to avoid him from doing that, and then we also tried to see if he's already looking at the student to distract him. But I think what's happening is when we try to prevent him from doing that, he has frustrations built inside, and when he comes home, he gets bad.
Yeah.
So we're trying to find an alternative behavior,
A
taking
transition,
him away from the
right.
fixation in the feet.
Yeah. How's that working?
But we're still figuring out, because it's hard, because we showed him videos that the feet stings, and we try to give
That's a
him-
great idea, right?
Give him like
That's actually an approach for, trying to understand.
they can smell something like
Yeah.
the feet smells like this, and
Right.
but for some reason he's like fixated to the feet.
So the video thing is and videoing them in the behavior is a great way to give the individual perspective of how other people are seeing him, right? Or seeing her in this behavior. And then using the video to try to coach on a different kind of behavior. And that's part of the social skills too, right? What's acceptable behavior, I should, in the classroom, and the kind of behaviors you're trying to promote are things that don't disrupt the learning day, right? Taking off your shoes, smelling your feet, you're missing out on what's being taught, right? And that's part of why we want you to keep your shoes on, kind of thing. And so it's hard, but you're right. You're trying to find different ways to transition it, right?
Trial and error.
Yeah, and then so it is a lot of trial and error, but it's also trying to figure out like what are the preferred activities he likes, and can you use that to transition him away from the feet too. Okay, and then all else fails, if this is really an obsession, then there's also that consideration for medication use. And so the SSRIs have been shown to improve kind of that obsessive, repetitive behavior that's related to anxiety as well. Okay. Yep.
All right, is that it? Can we all just give Dr. Yin
I don't need.
thank you so much.
So thank you. Thank you for coming out on a Wednesday. I know, with the weekend, 3-day weekend, right?
And let's give yourselves a big round of applause.
All right. Take care.